Okay, and this lecture will wrap up our discussion on the first part of chapter 12 of psychological disorders. So now we're going to talk about the different models of abnormality and how abnormal behavior is basically diagnosed, but also how it's defined according to the different models and maybe how it develops in individuals. So we have 4 different models that focus on different aspects when studying and explaining abnormal behaviors. So you have learned behavior, which is usually attributed within the behavioral model, thinking processes, which are the main focus of the cognitive model, emotional processes, and biological processes. So the emotional processes are focused on in the psychodynamic model, and the biological processes in the biomedical model. So as I said before, we have these 4 models. The biological or biomedical emphasizes biological processes that occur within your nervous system. The behavioral model is going to emphasize learning processes and observable behavior. Cognitive models are going to emphasize the conscious thinking process as well as behavior, although they're going to focus more on the thinking process, which we'll talk about in a minute. And finally, the psychodynamic model is going to emphasize unconscious or emotional processes. Okay, so let's get into each of these. First, the biomedical model. Again, they focus on factors that may affect the optimal functioning of your nervous system. So they look at a variety of things that is affecting that system and therefore resulting in abnormal behavior. So we have genetics. Of course, there are inherited developmental abnormalities that run possibly in your family's history, major depressive disorder, bipolar disorder, schizophrenia. These often run in families and are checked through a family history. Toxicity that could have occurred. So this is some sort of chemical poisoning that then alters the chemical makeup of your body or affects the nervous system, resulting in abnormal behavior. Any infection or disease that may have been contracted that causes chemical or even structural damage to the brain. Injuries, same thing, right? So any injury that may have occurred that causes structural damage to the brain. So traumatic brain injury is a good example of this. And then, of course, stress that causes hormonal effects over a long period of time. So this can also affect the optimal functioning of your nervous system. So the biomedical model is focusing on those physical things within your nervous system that are affected and result in abnormal behavior. There's a classic example of this. An individual diagnosed with a psychological disorder was Phineas Gage. Some of you may know who this is. Some of you may have never heard of him. He was a railroad foreman who had a very bad accident where a large iron rod actually went through his skull. He survived, which was miraculous, to say the least. But a lot of his frontal lobe was destroyed in the accident. So you'll see the picture of him there. He lost sight in one of his eyes. And he started engaging in a number of different behaviors, abnormal behaviors, right? So he was fitful and indulgent. He used a lot of profanity. He had sort of the intellectual capacities of a child. So he engaged in a lot of impulsive behaviors. Running away when he didn't want to do something and things like that. So he started engaging in these abnormal behaviors following an injury. And so, the biomedical model is going to look at injuries to assess or to attribute why an individual is engaging in abnormal behaviors. Now, it's not to say that all of the other models discount Phineas Gage's accident. Of course, that is one of the reasons that he's engaging in all of these behaviors, certainly, right? His frontal lobe was severely damaged, so he is going to engage in more abnormal behaviors. But what we're saying with the biomedical model is that that is the only reason they will use to attribute these abnormal behaviors. So Whereas the cognitive model might say, okay, well, yes, he had an injury, that's part of it, but there's also maybe some thinking processes that are occurring that are attributing to this. The behavioral model might say, okay, yes, there was definitely an injury that we have to account for. That most certainly is causing some of these behaviors. But perhaps also some of these behaviors are being reinforced in certain settings. And so he's engaging in those behaviors more. So other models don't, it's not to say that other models discount all of the things that the biomedical model looks at. They still consider those valid reasons for why an individual is engaging in abnormal behavior, but they just say there may also be other reasons as well. So people get very confused with some of the other models, and they think, well, isn't it obvious that there is a genetic component or there is a biological component? And yes, oftentimes there is. And the other models aren't ignoring those. It's just that they focus on the fact that there are other things happening too. So just a side note there. The biomedical model also looks at brain structures to determine abnormalities. So again, they're looking at different systems, right? So here we have two twins. One has schizophrenia, one does not. So the biomedical model is going to look at the structure of the brain and identify those abnormalities. So in this case, there's an enlarged ventricular space in the brain. Again, it's not that the biomet or the maybe the behavioral model, it's not that they say, well, there is no enlarged ventricular. Quite clearly that is happening. But for example, in a behavioral model, they would say, well, we're just going to look at their observable behaviors. That might be happening in their brain, but that's not the only reason or the only thing we're going to attribute this abnormal behavior to. Here we see cellular disarray in the hippocampus. So again, the biomedical model may look at things like this. So this is a schizophrenic patient on the right. And you see a large disarray or cellular disarray in this individual, whereas the picture on the left is a normal cellular, right? So you see them kind of concentrated sort of on the top, and there's a space, off below that, whereas the schizophrenic patient, it's kind of all over the place. They also look at brain functioning, right? So they compare brain functioning of an individual maybe who has a psychological disorder to that of brain functioning of a normal and individual, or better than normal, I would just say an individual who hasn't been diagnosed with a psychological disorder. As we discussed earlier, what is normal, right? None of us are wholly normal. So, but the pictures on the top, the two pictures on the top that you see, this is during a card sorting test. So this is often what they'll do is they'll hook up electrodes to the skull to get a reading of the brain. And then they'll have the individuals engage in some sort of task and they measure brain activity in that way. So the top two pictures are of an individual who has no psychological condition that's been diagnosed. And so you see that there's a good amount of activity in the frontal lobe, right? But someone with schizophrenia, their brain functioning looks quite different. So on their left frontal lobe there, you see a little bit of activity, but on the right, you see very little, right? So this is known as hypofrontality, which is a lower functioning in the frontal lobe of the brain. And typically with the biomedical model, especially in psychiatry, some sort of medication is used, okay, for individuals who've been diagnosed. And certainly for individuals who have some sort of genetic or biological component, right? Things that run in the family, or any, things that are going on at a cellular level, you do need medication to sort of balance that out. That is not uncommon. So antidepressants, SSRIs are used to sort of help balance the neurotransmitters that are sort of off or off balance in an individual. So again, all of these examples show that the biomedical model's main assumption is that if there's a psychological disorder present, it can be found through physical examination, right? It can be attributed to some part of the nervous system. And that is true for many psychological disorders. So, for example, we know schizophrenia and bipolar disorder do tend to run in the genes of the individual, right? And the genes of the family. Um, it's just that the other models also look at other factors that are contributing to this behavior. So, yes, there's a genetic component, but what else is also causing these behaviors to occur? So, they don't only attribute, for example, genes to the reason for abnormal behavior. And also, there are many disorders that do not have physical origin, right? Think about agoraphobia, for example, where we talked about in a previous lecture, being afraid to leave your house, right? That usually occurs, fears like that, any type of fear disorder usually occurs from experience of the individual, right? So they have a bad experience in a certain environment or with a certain stimulus, and they develop that very extensive fear response over time. Okay, that's not a genetic component there. So just something to think about. Okay, so let's talk about the behavioral model. So the main assumptions of this model is that abnormal behavior is the consequence of learning from the environment. Now, as I said before, this isn't stating that or completely discounting, the biological components as well. That is still taken into account, but basically what this is saying is that we don't just say, oh, schizophrenia runs in their family. Okay, the end. They say, okay, schizophrenia runs in their family. It is genetics. They all get medication for that. But also, what else can we do? How else can we change their environment or reinforce their behavior differently? And maybe we can also help with that behavior rather than only depending, for example, on a medication, right? Or only attributing genetics to the cause of these behaviors. So within the behavioral model, there's really no qualitative difference between normal and abnormal behavior because we view them as being learned in the same way, right? So there's typically not a distinction placed between the two. We don't typically come up with definitions for abnormal versus normal behavior. It's all just considered behavior, right? Now, whether or not it's maybe socially acceptable behavior or not is something that can be defined. But we don't say, oh, that's an abnormal behavior. We might just say, well, that's a behavior we don't want to see as much of. So, how can we make that behavior decrease or maybe not occur at all, right? So, through the use of classical and operant conditioning, as well as social learning, all behaviors, according to the behavioral model, are learned in this way, whether they are considered normal or abnormal behaviors. So, according to the behavior model, there's usually a learned association between two stimuli and negative emotional states. Okay, so again, like I mentioned before, with fear or phobias, something in the environment was paired with the feeling of anxiety or some negative emotion. And now, whenever that individual is in the presence of that stimulus, they experience emotional distress, right? So it's due to a learning history. This can also occur due to the lack of positive reinforcement in the environment. So remember when we talked about operant conditioning and reinforcement processes, in order for a behavior to increase in the future, it has to be reinforced. So if you want normal or good behaviors to occur, there has to be reinforcement for them. If there is none, they're not going to continue to occur. Now, um, so, engaging in certain emotional or depressive behaviors are often inadvertently reinforced by others, right? So, think about when someone is lamenting or they're really sad, maybe they're crying. Typically, other people in their social network are going to try and provide some sort of comfort for them. They're going to ask if they need anything. Um, they're going to try and help them, or even they just let them talk about it. This inadvertently reinforces the behavior because if you think about it, that individual is actually getting attention, right? Positive attention from their social network by engaging in these sort of depressed behaviors. Okay, so just something to think about. So it's not that those aren't real feelings that they're having and real emotions. The behavioral model is not saying that people are just faking it. That's not what we're saying. What we're saying is they may engage in these depressive behaviors because they are truly anxious or depressed, right? But you might actually see an increase in those behaviors because of the reinforcement they then are provided for them. Okay. So they may start at lower levels, but they actually increase because people are inadvertently reinforcing those behaviors. You can also apply this to things like schizophrenia. So there was actually a study done many years ago, I think it was in the 60s or 70s, where basically they had individuals at a asylum, at a home, who were on medication. Okay, so they're schizophrenics, they're on their medication, which according to the biomedical model, if they're on their correct medication, the correct dose, we shouldn't see those schizophrenic behaviors anymore, right? Because they don't look at any other reasons, right? So they look at the biological process, they do a medication if needed, and that's the end. But what was happening with one of these individuals is their grandiose talk and hearing voices and talking to people who weren't there, so their hallucinations were actually getting worse and worse and worse for this particular lady, this particular individual. And they couldn't figure out why. So they had a behaviorist come in and sort of observe her. And after observing this individual for a while, he said, well, she's being reinforced for all of those behaviors. Every single time she has a new story or there's a new individual she's interacting with, the nurses ask her about it. They ask her to describe it. They want her to talk about it, right? Her psychiatrist at the time was encouraging her to go into great detail about these things and talk about them. So she's getting a lot of attention for these things. Additionally, he also observed that when she engaged in sort of these hallucinations or hearing voices and talking to them, some nurses would give her like magazines to get her to be quiet. They were her favorite magazines, right? So think about it from the side of reinforcement. If from the individual's point of view, if I engage in these behaviors of talking to the air and hallucinating or saying I'm seeing things, and then I'm given my favorite things, what is that going to do? That's going to increase your behavior in the future. Now, it's not to say that she didn't experience those things at some point with her psychological disorder, but they increased and they were increasing because they're also being reinforced, right? So they did a number of things where people started ignoring her or redirecting her. So instead of talking about the voices she heard or the people they saw, they would ask her about a book she read or, something in the here and now to get her to talk. So she still gets attention. She still gets that positive reinforcement, but for more normal, appropriate behaviors, right? And they did see a decrease down to a normal level with medication where she didn't engage in those behaviors anymore. So inadvertent reinforcement is a strong thing. It can really affect behavior. Something to think about. Finally, there's something called learned helplessness. So this is where the individuals are unable to escape any unpleasantness in their environment, no matter how they behave. Okay, we see this all the time with individuals who are under high amounts of stress all the time. So this is basically saying no matter how they behave, that stress is never removed, right? So that what we would say aversive stimulus, right? That feeling of stress. Think about when you're stressed. It's an awful feeling, right? You might actually feel heavy on your chest or like sort of ill in your stomach. You're not hungry. Like you just don't feel great. So when you experience that for a long period of time, no matter how you behave, okay, so you're engaging in all of these behaviors and all of these behaviors, and that horrible feeling, that aversive stimulus never goes away. Eventually, you stop behaving altogether, right? And that's when depression occurs. Individuals who can't get out of bed, who can't go to work, who can't see other people, who can't do anything, right? Can't take care of themselves. It is often from learned helplessness because no matter how they behaved, they could not remove some sort of aversive stimulus that was occurring. Or affecting them, right? So they stop behaving altogether. We see this in labs all the time with animals. especially with rats. So a series of studies were conducted many, many years ago on learned helplessness. So they basically shock the rat, right? So first they teach the rat that if you press a lever, you won't get shocked, right? So the rat learns that when they get shocked, they press the lever and it turns the shock off. And then what they do, it's really sad, but they continue to shock the rat, even though they press a lever. So at first the rat presses the lever over and over and over again. They press it many, 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 many times. Then they start jumping, they start trying to crawl out of the cage, they start trying to do any behavior to get away from the shock. But eventually, they just sit in a corner and they just accept that they're going to get shocked and they don't behave at all. And this can be applied in the same way to humans, right? When you're feeling some sort of aversive stimulation, whether it's pain or anxiety or stress, you'll engage in a number of behaviors to remove that aversive stimulus. But if it remains, if none of the behaviors you engage in are successful, then this can lead to depression and not engaging in any behavior at all. So any of these being present, or even all of these, can lead to an increased vulnerability in depression, according to the behavioral model. Here's just a diagram of an example. So let's say an individual has poor social skills. This can result in any number of these. So if they don't have good social skills, they may not make good friends, they may not earn good jobs. Essentially, they're given fewer reinforcers, right? Fewer friends, fewer people to interact with, less pay, maybe, things like that. They might be rejected, right, because of their poor social skills. So they might actually gravitate to people who reinforce and confirm their negative self view. So they're rejected by people who don't want to hear about that, right, or don't want to deal with someone with poor social skills. So then they gravitate to people that actually reinforce that. So it gets worse, right? And this can all lead to an increased vulnerability of depression.